Sorry, but I think we might be getting voice, and that is being streamed live right now.
Sir, Professor Sinha is in another interview, so can we start and we can start when he joins. We can do the proceedings before.
बहरा जी शुरू कीजिए.
Am I audible, sir?
Yeah.
Yes.
No, what I'm saying, I can start.
Bhera ji, I think we can start.
We can
Yes.
start. I will give a little presentation on role of yoga and meditation in post-COVID care.
Sir.
Okay.
Okay, sir. Let me start, sir.
Yeah.
Good afternoon to all. Respected Sri A.K. Gautam sir, Director of Finance, Sri D.K. Patel sir, DHR, Sri Ramesh Babu sir, DO, Sri Ujjwal Bhattacharya sir, DPRO, and DCOM sir, Sri Mandal sir, Dr. M.C. Misra, the ex-director and emeritus professor of JP Trauma, Apex Trauma Center, AIIMS, Professor Kapil Dev Soni, additional professor of JP Trauma, All India Institute of Medical Science, New Delhi. All my dignitaries present through this MS Teams and YouTube. All the members of NTPC family and the medical officers, doctors, Dr. A.G. Rizwood, CMOCC, and dear friends. In the continuation of the webinar series by the Corporate Medical Cell, today we have
Sorry, but I think we might be getting voice, and that is being streamed live right now.
Professor Sinha is in another interview, so can we start and we can start when he joins. We can do the proceedings before.
बहरा जी शुरू कीजिए.
Am I audible, sir?
Yeah.
Yes,
you
yes.
No, what I'm saying,
sir,
I can start. You,
Bhairaji, I think we can start.
we can
Yes.
start. I will give a little presentation on role of yoga and meditation in post-COVID care.
Sir.
Okay.
Okay, sir. Let me start, sir.
Yeah.
Good afternoon to all. Respected Sri A.K. Gautam sir, Director Finance, Sri D.K. Patel sir, DHR, Sri Ramesh Babu sir, DO, Sri Ujjwal Bhattacharya sir, DPRO and DCOM sir, Sri Mandal sir, Dr. MC Misra, the ex-director and emeritus professor of JP Trauma, Apex Trauma Center, AIIMS, Professor Kapil Dev Soni, additional professor of JP Trauma, Polyana Institute of Medical Science, New Delhi. All my dignitaries present through this MS Teams and YouTube. All the members of NTPC family and the medical officers, doctors, Dr. A.G. Rizwood, CMOCC, and dear friends. In the continuation of the webinar series by the Corporate Medical Cell, today we have
policy document which we were just discussing.
in COVID patients. So today we have eminent faculties, Professor MC Misra, Professor Sanjeev Sinha, and Professor Kapil Dev Soni will deliberate on the topics of importance for us. Before we start, let us observe 2 minutes silence for the departed souls who have left us for heavenly abode during this COVID second wave. So I request all of the spectators, all of us, to please observe 2 minutes silence in the memory of our friends and families who have left us.
Therefore, my submission is, number one, if university is contemplating its development, that's my expectation. And the second thing, in chair, I would like to say is, which would be a concern would be university and things of its morality of patients. In chair, there is a draft regulation which has been put on by the National Medical Commission in public domain in government level.
Thank you.
Especially in the context of guidelines for the purposes of chargeability of fee in unaided institutions.
Dr. Behra,
Yes, sir.
I have sent you a presentation, PowerPoint, and if you can put up, then we can begin. Unless Dr. Sinha has come and he would like to start.
That have medical colleges under their ambit in terms of its economic viabilities and sustenances. And therefore, that is one important concern I thought I should bring to the knowledge and notice of the learned members of the governing council and also the honorable vice chancellor and chancellor respectively.
डॉक्टर पहला आपके पास नहीं होगा तो इनको डॉक्टर रिश्वत को मेल कर दीजिए, he will upload.
मैं भेज रहा हूँ.
उनको नहीं तो विषय को लोड कर दीजिएगा. Actually डॉक्टर बेहरा is out of session sir. तो if you are facing any difficulty then you can mail to विषय और ये डॉक्टर रिश्वत.
Okay.
Ensuring that the interest and long-term interest of the university, especially in regard to the financial viability and feasibility, is that these are the things which I thought I was bringing into the knowledge and focus of all concerned through the permission of the chair. Thank you very much, Chair, for permitting me for the same. Thank you, Lady. And for the second point, I would strongly suggest that depending on, you should study those guidelines.
Dr. Sandeep Sinha is also joined. Dr. Sandeep, welcome, Dr. Sandeep Sinha.
Then let him begin.
Professor Sinha, shall you start, sir?
प्रोफेसर सिन्हा आप म्यूटेड हैं. सर आपका थोड़ा सा ये वॉइस काफी लो आ रहा है.
Can you hear me now? Now it is okay.
सर वॉइस थोड़ा कम आ रहा है.
Dr. Behra, can you hear me now?
Yeah.
Now voice is okay?
Now it's okay.
Okay. So can you please share my slides? Next slide, please. So I have been allotted to speak on post-COVID syndrome or post-COVID sequelae. So I just want to tell that there is a COVID period and generally it is between 2 to 14 days. And when patient is having three kind of symptoms, either patient is having asymptomatic, mild disease, moderate or severe disease. So what happened in mostly between 80 to 85% patient having either asymptomatic or mild disease, and
slides are not visible.
Sir, you have to share because I have sent the slide to Dr. Behra.
सर मैंने स्लाइड शेयर कर दिया. आवाज आ नहीं रहा सर?
नहीं अभी तो नहीं आया. आपने सेपरेट स्लाइड किया है शेयर. If you allow, then I can also share the slide.
सर आप कर लीजिए शेयर प्लीज.
डॉक्टर सिन्हा आपने शेयर कर लीजिए सर.
Okay. So can you see my slides now?
Yes.
Yes.
So I was just telling that we have three kind of mild, moderate or severe COVID disease, and in mild disease we have symptoms of fever and we have symptoms of body ache, headache, and we have loss of taste, loss of smell, and some patients also have complaint of pain abdomen, and they have complaint of loose motion also. And what we advise in the mild disease, that patient have to stay at home and just measure the oxygen saturation level. If it is more than 95%, then they have to do home quarantine and they have to follow appropriate COVID behavior. And they have to take paracetamol for fever and multivitamins and plenty of fluids and high protein diet. And if patient is having oxygen saturation less than 93 or 92%, then they have to contact to the nearby doctor, and as per doctor's advice, they have to take the oxygen at home, or if required, then they have to be shifted to the hospital, and we have to treat them as a moderate patient. And we have to start the oxygen by using different devices and try to maintain oxygen saturation more than 95%. And then if patient is having if patient is unable to maintain the oxygen saturation, if it is less than 80%, then we have to shift the patient in the ICU, and we have to use the NIV, or if required, then we have to ventilate the patient. So these are kind of briefly I'm telling about the COVID, and then I'm coming about the post-COVID syndrome or the post-COVID sequelae. So we have like post-COVID OPD in our AIIMS New Delhi, and we see most of the patient coming after recovery, and then when they come to the hospital or OPD, or when they talk on phone, they are mostly complaining of body ache, or they are having kind of loss of appetite, pain abdomen. Most of the patient complain either they have constipation or they have loose motions. And then some patients also having complaints of mood disturbance, either they have kind of anxiety or they have kind of depression. And then we have also seen patients coming with the complaint of headaches. Some patients have dizziness, and some patients having complaints of pain in the lower limb, maybe because of deep vein thrombosis, and some patients having hepatitis. It could be because of elevated SGOTPT or liver enzymes, or there is a elevated bilirubin also. And there are some patients complaining some complaints related to kidney, and they have kind of acute kidney injury or proteinuria or hematuria. And as I already said about the GI symptoms, diarrhea, abdominal pain, nausea, vomiting, and loss of appetite. And it is very important to tell to the patient at the time of discharge, then when they are going home, that they have to be taken care about their blood sugar level, if they have received the steroids, or they are known case of the diabetes. So it is very important to tell them when they are going home, they have to be take care about their blood sugar or diabetes. And similarly, they can also have complaints of some cardiac problems, like they can have irregular heartbeats, they can have some myocardial injury, and sometimes they can have low blood pressure also. And in skin, they can have some complaints like urticaria or itching. So these are some common symptoms patient. We have seen patient coming to the OPD, and they have these problems. So coming to, I just want to come about the most important thing that we are seeing nowadays, that patients who are having lung injury or who are having ARDS due to COVID pneumonia, they are when they are coming out of ICU or out of hospital, so we have seen they are unable to maintain their saturation on oxygen. So sometimes we need to give them home oxygen, and it has been seen that it may be because of post-COVID fibrosis or in some fibrosis in the lung, or if patient is having any respiratory disease, previous history of respiratory disease like COPD, ILD, and bronchial asthma. So these type of patient may require home oxygen or antifibrotic drugs at the home for a certain period, and they have to be in touch, in contact with their doctor for the kind of management. So here we also see many patients have complaint of cough. So what are the common causes of cough? So it has been seen that there could be respiratory causes or non-respiratory causes, and we have seen that respiratory causes may be because of some effect post-viral cough, or it may be because of underlying upper respiratory tract syndrome, or maybe because of asthma, COPD, or if patient is having upper respiratory tract infection or lower respiratory tract infection, or there is an underlying history of bronchiectasis, post-tubercular bronchiectasis, lung fibrosis, or patient having underlying pleural effusion or pleuritis. And if underlying history of heart failure or pericarditis, then can also patient have kind of cough. So I've already discussed about the lung fibrosis, and I just want to tell about the treatment of lung fibrosis or pulmonary fibrosis, that it has been seen that many patients, when they are coming out of hospital, they have fibrosis or ground glass obesities in the lung. You can see in the CT scan, and they are unable to maintain oxygen saturation, and their saturation is less than 90%. So in that case, we need to give oxygen inhalation to these patients, and in that case, we don't want to keep patient in the hospital because there is a chance of getting hospital infection. So we keep these patients to the at home, and we provide them, or we ask the patient to arrange home oxygen or oxygen concentrator, and we ask them to keep in that touch with your doctor, and as per requirement, we give them oxygen 2 to 3 liters per day per minute, so they can maintain their oxygen level around 95%, 94 to 95%. And there are certain drugs like antifibrotic drugs. We have nintedanib and we have pirfenidone. They are also having, it has been seen, they have also some effect in the treatment of post-COVID fibrosis. But several studies have been done and trials have been done, and it has been seen with the time this fibrosis get improved, maybe after 8 to 10 weeks. So coming to the neurological sequelae, I have already discussed that patient can, most commonly they have complaints of sleep disorder, they have insomnia, they have memory complaints, they have kind of fatigue, they have myalgia, and sometimes they have severe headache. So these are some common symptoms we see in the patient who are having post-COVID sequelae or post-COVID syndrome. So coming to the cardiovascular sequelae, so we have kind of acute manifestation like cardiac injury, myocarditis, and there is a patient can have arrhythmias also. Some patient complain they have arrhythmias, and some patient can have like cardiogenic shock. So these are some common symptoms in the acute manifestation, and some symptoms like post-COVID manifestation like myocardial inflammation, myocarditis, or myocardial fibrosis, or maybe there is arrhythmias, or there may be cardiomyopathy. These can occur, the frequency is not very high, but they have seen some patient can have these problems. And if patient is having underlying prior disease, then they can have more chances of getting these kind of diseases. So diabetes is very important. I said that many patients are getting treatment, high dose steroid, commonly in the moderate to severe disease, and diabetes is one of the comorbid state where patient can get the COVID infection. So one have to be very careful once patient is admitted or when you are discharging to the patient, and then one have to be very careful about the treatment part, and we have to do regular blood sugar monitoring, and we have to treat the patient. If required, then we can give the oral hypoglycemic agent, or if required, then we can start the insulin as per the blood sugar levels. Another common complaint is emotional and behavioral concern, and we have seen that many patients who have been in the hospital or who have been in the home quarantine, they have feeling of isolation or loneliness, and this is very common complaint nowadays we see in the patient who are having post-COVID sequelae or effect. So they are having kind of anxiety, they have feeling of hopelessness, sense of hopelessness, and they also feel that they can have a kind of anxiety. So if required, then we have to treat them for the anxiety and depression. Another common complaint we see in our outpatient, post-COVID outpatient or patient who are calling on phone, they have complaints of fatigue. So they have complaint of muscle pain, joint pain, and sometimes they are having mild headache, and they are having early fatigue. They are telling they cannot walk, they want to lie on the bed all the time, and they are unable to, they don't have like feeling of eating, and they are very fatigued. So this is one of the common complaints that we see in patients who are having this post-COVID effect. So these are some common common things I want to discuss here, and I'm ready to take question if any questions are there. Dr. Vera, can you hear me?
Yes, sir, you are audible.
Yes, sir.
Thank you, sir. Thank you for describing the common causes of post-COVID symptoms that we come across, and what are the...
Thank you.
Dr. Behra, Dr. Sinha will, are there any questions for Dr. Sinha at this point of time?
Yes, sir, I have a question. Professor Sinha.
Yes, sir. Yes, sir.
Sir, I have a question that in how long should we prescribe the blood thinners, that is the anticoagulants or antiplatelet agents, and what are the markers for the duration of treatment in these cases?
First question is how long we have to give blood thinner. So generally, we start the blood thinner in the patient who are having a low, moderate to severe disease, and we start low dose low molecular weight heparin, and during admission we keep on giving, and when patient goes to home, so either we can continue with subcutaneous doses, or if required, then we change them on the oral blood thinner. And I would like to advise them when they are going to home, they have to be do INA and PT and INR on regular basis, and they have to be in contact with their doctor.
Sir, the D-dimer or any other markers are also responsible for the duration, or if the D-dimer has come normal?
You can do other markers also, but if patient is on discharge on the oral blood thinner, then we have to do PT-INR. And D-dimer is also important marker, and other markers, other inflammatory marker if required, then we can also do like CRP or other markers if required.
Yes, sir. During this post-COVID symptoms, many of the patients are advised steroids, either they are Dexona or Omnacotil or Defcort, methylprednisolone. And some patients, they keep on continuing without tapering or without the doctor's advice. So what precautions should the patient or the doctors take to give steroids in the post-COVID patients?
So there is a certain guideline. I think if your patient is having mild disease, so as per guidelines, we don't give a steroid. And if there is a requirement of steroid, like there are certain indication. If patient is having high-grade fever, even after 7 days, or there is raised inflammatory markers, or there is a severe cough, or there are chances of COVID pneumonia, then we give steroid for 7 to 10 days. Similarly, in moderate to severe stage, we give the steroid, and we have to be very careful during steroid course. We have to do regular blood sugar monitoring, and if required, then we have to give patient oral hypoglycemic agent, or we have to give the insulin as per blood sugar levels. So this is very important, and we have to not prolong steroid is not required. So there are set guidelines, we have to follow those.
Rightly, sir, in post-COVID treatment, closely, and every day we should monitor the blood sugars and never discontinue the anti-diabetic medicines in the post-COVID situations. And if you are on steroid, then extra or added amount of the blood sugar medications or even insulin is sometimes required.
Yeah.
I'm not able to see any. Yes, sir.
Professor Sinha, just blood thinner ka issue में, suppose somebody discharged D-dimer is okay in a mild to moderate case, but D-dimer is okay within the normal limit of 500, but he is a diabetic patient. Should we continue ecosprin for a month or so, or he can discontinue?
So ecosprin is an antiplatelet. So if patient is having underlying comorbidities like coronary artery disease, then we can continue in patient of diabetes. But as alone diabetes, we, as per recent guideline, I understand there's no need for ecosprin, but Dr. Mishra can add if something is there.
No, I think it's all right just to continue for a month and then stop it. But people do say that the other low molecular weight heparins are better, newer ones. Eliquase, the trade name, which is very popular these days.
Yes.
What is this? What is its generic, Sanjeev? Pixaban or something like that. Yeah, oral.
Dr. Behra, we can proceed and question last में ले लेंगे.
Yes, sir. Actually, Professor Sanjeev will be off, and he has got another.
Okay.
So one more question has come, sir. How to handle headaches in the post-COVID situation?
So, as I said, that headache is one of the common symptoms we have seen, or in the post-COVID OPD, or patient is calling on phone. So we have to advise to the patient. One thing we have to advise to the patient that they have not to be panicked. Now they are recovered. We have to give the good counseling to them, and we ask to them to take good high protein diet, take multivitamins, and if required, then we can give the painkillers also. And like either you can give paracetamol 650 milligram SOS or 6 to 8 hourly, or we can give some other painkillers. And main thing is counseling of the patient. We have to tell the patient that you have recovered from disease, and now they need not to worry. It's a matter of time, and some more days will take. And second thing, if patient is hypertensive and he's having underlying hypertension, then we have to ask them to measure the hypertension, and their blood pressure have to be normal. And if required, then we have to treat blood pressure also.
So one more question is, for how many days after COVID need to be cautious?
Regarding general health care?
Yes, sir. Post-COVID care, for how many days we need to be cautious?
Okay. So, for example, if patient is become all right within 10 to 14 days, then they can, as per recent guideline, after 14 days, if patient is all right, he did not have any fever for last 3-4 days, and he is feeling well, then he can join the job. He can go to the office also, and but they have to take appropriate COVID behavior. They have to follow the appropriate COVID behavior. They have to wear the mask, and they have to keep the social distancing. They have to do the hand hygiene, proper hand hygiene, either by using soap or by using alcohol-based hand sanitizer. And I think after 14 days, they are feeling all right. They can join the office, but we have to tell them they have to use the appropriate COVID behavior.
Sir, one more question has come. Once you stop steroid in mild to moderate case, when can you stop sugar medications?
So it depends on your blood sugar levels. If your blood sugar levels are all right, and you can taper off the OHAs, and then slowly you can stop it. And I would like to tell also here that we have to use the proper diet also. We have to take diabetic diet or low sugar diet or low carbohydrate diet, and we have to do mild exercise. Like if you are at home, you can do 6-minute walk test, you can do yoga, you can do breathing exercises. So these things are also going to help. And you can do breath hold exercises, you can do incentive spirometry. So these are some exercises we have to advise the patient, and we have to take care about. You can take the like you can measure the blood sugar at home. If it is normal, then with consult with your doctor, you can stop that.
Dr. Behra,
Yes, sir.
in this question, he has asked in mild to moderate. One thing should be very clear to all the attendees. There is no need for steroids in mild cases. They must not take steroids. It's only in moderate and severe pneumonia steroids are indicated in admitted patients, and moderate cases patients can take at home under the guidance only during the second week of illness. In first week of illness, in mild patients, otherwise also steroids are not indicated. So it has been overused, it has been misused, so should we say, and we are seeing the problem of this mucormycosis and all that, and flaring of diabetes and blood sugar levels going up. So there have been basically inappropriate use, unindicated use of too much steroid has created a lot of problems.
Right, sir. Actually, steroid should be never taken on self-medication. It has to be always advised by a doctor, and never in the mild cases and never in the first week of the disease if there is no moderate to severe complications of the COVID. So this has to be used cautiously. One more question is that how long does it take to recover fully from post-COVID symptoms?
So it has been seen that if patient is like having no fever within 14 days, like if patient is all right at the 14 days and they did not have any history of last 3 days fever, so then after 1 to 2 weeks they feel all right. Generally, whatever patient are coming in our follow-up, they told they are feeling all right after 1 to 2 weeks, and they can join the office if they are feeling all right. And they, as I told you earlier, that they have to take good diet, they have to take multivitamin, they have to do light exercises, and they have to do yoga. And it's very important, we have to do counseling, good counseling to the patient.
Then one personal question from some anonymous. I am feeling continuous pain in my heart after taking omnacotil. Sleeping is also sleeping problem is also there.
So what could be the problem they are having in the heart? Is there any palpitation or arrhythmia?
No answer to that. They have only feeling that he is having pain in the heart.
So this is post-COVID?
Yes, sir, post-COVID. He is on omnacotil.
So he must be on tapering dosage of steroid. He's not giving full history as told by Professor Mishra also. We are generally not giving steroid in the mild cases. If patient is having moderate to severe disease, then we give steroid. So if patient is having like he have been given steroid during moderate to severe disease, then we discharge them on tapering dosage of steroid and slowly we off them. And sometime, as I mentioned in the one of the slide, like cardiac side effects, so patient can have arrhythmias. So if he is having something like that, then we have to meet with the doctor and he have to do ECG.
So one more question is, does loss of smell last for a long time even after recovery?
Yeah, it may last for sometimes more than 4 weeks, but it generally would return. The sense of smell would return. You don't have to do anything for that proactively. It will just in natural course, it would be okay.
Yes, sir. One more is that after how many days of recovery vaccine may be taken? This is a very pertinent question everybody is asking, but government has also come with guidelines. And if any test is required before taking a vaccine?
So there is a very strict guidelines now. They came recently, and as per recent guideline, if you are recovered, like today you are recovered, so after 3 months you can take first dose of vaccine. Okay, so this is very clear now. There is a clear-cut guideline, and if you are taking co-vaccine, so you can take after 3 months first dose, and then after 4 to 6 weeks you can take second dose of the co-vaccine. In case of Covishield, first dose you can take after 3 months of your recovery of COVID infection, and then second dose you have to take 12 to 16 weeks, after 12 to 16 weeks. Because there is a study and it's shown that after first dose of Covishield, there is about 80% efficacy comes for production of the COVID infection.
Sir, any test is required before taking the vaccine?
No test required. Not at all.
There is no contraindication. In certain patient like pregnancy and in the patient who are less than 18 years, because we have not done trial, we have just started trial for 2 to 18 years of age, and so we are waiting for result. And then number 3, breastfeeding females, where we don't.
Sir, one more interesting question is, what specific restrictions or inclusions should we include or exclude in our diet after COVID?
No restriction. Continue your fluid intake, continue your fresh fruits, continue your diet. Good diet, sattvic diet, what we call. I am a vegetarian, so I'll recommend vegetarian, but if you are a non-vegetarian, you want to take egg, a good well-boiled egg, omelette, whatever. There are no specific, but it should be a healthy diet, more of proteins, less of fat and carbs, as Dr. Sinha has already mentioned. So no restriction. Give more emphasis on fresh fruits, fresh foods, home-cooked food, and do some exercise, yoga, which I'll give a little presentation after this. So that will take care of your weakness, and also you will feel more energetic, and you should not be feeling excessive anxiety or stress. I think that is causing more problem than actually the COVID itself.
Yes, sir. One patient has asked that the dry cough is persisting even after 1 month of recovery, and he has taken multiple cough syrups. What should he do?
It is not uncommon. These kind of symptoms, even if people can recollect, whenever we used to get a non-COVID viral fever in the past with upper respiratory tract involvement, the cough generally takes longer to settle down. And that is where some of the interventions, we can have indigenous interventions in the form of Ayurveda, in the form of naturopathy, instead of heavily depending on allopathic medicines on that resolution of that cough, which will naturally involve moderation. Use the steam in moderation, not excessive. Excessive use of anything should be avoided. And then you can take certain Ayurvedic preparations also for chronic cough. If your chest X-ray is okay, your pulmonary function is okay, and it is coming out that most of these people have their pulmonary functions okay, they are normal, and still there is some. So it's kind of irritative cough. It's a what we call the tracheitis, which can persist, because ultimately this virus or any virus cause systemic inflammatory response, and in some people it lasts what we call short COVID within 4 weeks, and some people it is long COVID, which is longer than 4 weeks. It does take some time for resolution, but it will get resolved. The only thing, one should remain in touch with your doctor to so that we make sure that we are not missing something else.
Yes, sir.
Dr. Pera, any other question?
Sanjeev, you have to go for a TV debate.
Sir, more meetings. If your permission, with your permission, can I?
हाँ नहीं वो डॉक्टर बेरा ने बताया था बिल्कुल. Any other question for Dr. Sinha, Dr. Bera?
Yes, sir. At what time CT scan is to be repeated in order to diagnose post-COVID fibrosis?
Sir, can I answer, or you would like to answer?
Please answer.
There is a lot of controversy in this question. So, first thing is, like if patient is having severe, as I said in the beginning, the patient is having ARDS or severe lung injury, then or they are on ventilator support or high requirement support, then we need to give low, now I'll add the word low dose CT, so it have less side effect on body. And first you do the chest X-ray, if required then we do low dose CT scan. And if there is no need for follow-up CT, I think if patient treated, I said in the beginning that patient can do in the follow-up, like Professor Mishra also said, we can do pulmonary function test and we can do 6-minute walk test in the follow-up, and if required then we can do chest X-ray. And if it is mandatory, then we need to do. It's depend on patient to patient condition. Otherwise, yes.
Let your doctor prescribe it. You don't do CT scan just because your cough is persisting. That's not the indication for CT. The other thing is, first get simpler things like pulmonary function. So, because CT scan is not a treatment, it is an investigation which is complementary to clinical examination. So, get a pulmonary function. If you are requiring, you are still breathless on walking, if you still feel that when you are climbing stairs, you get breathless. So, at that point of time, get your pulmonary function and then you consult pulmonary physician and let them decide, because CT scan is not something which you would do for fibrosis. It will all depend whether you are requiring oxygen supplementation still after many days of recovery for a longer period. So all those things the pulmonary function would determine, and most of the times if you can improve your lung capacity by pranayams, by incentive spirometry, by breathing exercises, that would help you much more, and that should begin from the very beginning, from the first week itself, so that you don't develop that fibrosis. Don't let. But yes, some patients who would go to ICU, they may not be able to do that much aggressive physical, the chest exercise, lung exercise, breathing exercise. So in those people, some fibrosis will take place, and that might be, and that is one of the reasons why the steroids are given for as an anti-inflammatory against the cytokine release, and also it will take care of, as an anti-inflammatory drug, it will also reduce the chances of fibrosis in severe, moderate to severe cases. In mild, in the first week, no steroid, no CT scan. Only around 7th or 8th day, let your doctors decide whether you need to do CT scan, whether you need to start some dose of steroid with very carefully calculated dose, not excessive. So I think this is one should not self-prescribe. People have done 3 CT scan within a span of 1 week. That should not be done. CT scan is not a treatment. It is only a diagnostic modality.
Yes, sir. Thank you so much. Before Professor Sinha leaves for another meeting at 5 minutes, last question to him is, after how many days you may stop zinc and multivitamins?
You can, like if patient goes to home after 14 days, we can give another 7 to 10 days or 2 weeks, not more than 2 weeks. But
so after 2 weeks of
take a good diet, healthy diet.
What was the question?
Yeah, please.
What was the question?
How many days take the multivitamins after discharge?
No need. If your diet is okay, if you are able to eat what you want to eat, no need of any supplements.
So most important thing, you have to take healthy diet, you have to take seasonal fruits, you have to take green vegetables. If you are non-veg, you can take eggs and non-vegetarian diet, and you can take milk. So these supplements are generally not required.
Supplements are only for those who are chronically ill. If you were healthy, otherwise you have resumed your normal diet, you are able to drink your milk, you are able to eat your fruits, if you are able to eat your dal, chawal, no need for supplements. If you are able to take shikanji, if you are able to take coconut water, there is no need. It's only in some groups like elderly, those who were already compromised nutrition because their intake was compromised even before COVID. So these are, some groups may be needed, but as a most people do not need any supplements whatsoever if you are able to take your normal diet, what you generally like to take and consume. Because this weakness will take some time to go, maybe 2 weeks, maybe 3 weeks. Some people have more weakness, some people have less weakness, so it all varies. So I think remaining in touch with your doctor is extremely, extremely important, and discuss and then make a decision. Because we have discussed this supplements thing also, which is overused in COVID.
So thank you, sir. Now we can.
Thank you, sir. Thank you very much, sir.
Okay, thank you. Thank you. Wonderful. It was a very informative presentation.
Thank you, Professor Sinha. We understand your hectic schedule, so still you have been able to spare time for us. Thanks a lot from the entire NTPC family.
I would like to thanks to Professor Mishra and all members of officers of NTPC and Dr. Soni for giving this opportunity. Have a good evening.
Thank you, sir.
So now continuing the session on this post-COVID care and the fungal infections in post-COVID patients. Let me now welcome Professor M.C. Misra, who is a stalwart in himself, and he has been very particular about the COVID treatment and COVID behavior with all the COVID appropriate behavior. So now let us listen from him. What are the reasons for the second wave and what's in future for us? Should we be worried? Should we be prepared? Or what's in line for us in the future? Professor Mishra, sir.
Thank you, Dr. Behra. Thank you, Dr. Sanjeev and Dr. Kapil and Mr. Patel and Dr. Risbod and everyone from NTPC family. This is a time for, as rightly Dr. Behra remembered, those whom we have lost during past 15 months and more so in past 6 weeks, because this second wave of infection has been a real challenge for all of us in the country, for the medical fraternity, for the public at large, for the organizations like NTPC, because the challenge was how we can keep safe everyone in the organization. And NTPC, I must compliment, that has been proactive in this direction from the very beginning. We have been proactive in issuing guidelines from last year itself, and even in March, and then again we revisited the guidelines. But naturally, there has been breach of protection for many of us, and we contracted the illness, and although most people recover without any problem, but some of us also got sick, very sick, and we could not save such severe disease from severe disease. And the reasons, as all of us have discussed, for this sudden rise of infections was largely because everybody thought that COVID is over. When we were getting reduced number of infections every day, although the number was still around 10,000 in the country when it started rising. It started rising first in select states like Maharashtra, Kerala and Punjab and Chandigarh. But as India is a large country with 28 states, 9 union territories, every state behaves like a country, because if you look at Europe, many countries are smaller than our states. Basically, if you look at UP alone, the population is 22 crores. And if you look at UK, its population is 6 crore. America's population is 33 crores. So you can imagine what are we dealing with. And then naturally, we have density of population also is something to do where physical distancing is not so much possible. But in this second wave, if you look at the people from middle and upper middle class were mostly affected, while in the first wave they were spared. Maybe they took more precautions, they worked from home and they listened to the guidelines. But as we gave up the preventive measures through February and March, and then came Holi, the election, the Kumbh, and then the Eid, everything put together led to the increase. That was foremost reason for the increase in the infections. And then obviously the mutations also contributed immensely in every state, because if you look at Maharashtra, there was a double mutation, triple mutations were talked about. Karnataka has 44% mutations, Punjab, UK mutations. Then this Kisan Andolan has been going on. So there have been multiple reasons. And then naturally the super spreader events. People were participating in marriages, people were holding parties, events, and all this, because everybody thought it's normal to do all this. So everything contributed towards, and then university campuses were open, the classes began. So, and we denotified COVID hospitals from 1st of February. So that was something which definitely put together everything contributed towards. And what we saw more when the genomic sequencing was done in January, February, it confirmed that there were mutations, but most of them were our own mutations within the country, and there were about 800 genomic sequence of that UK variant or South African variant or Brazilian variant. So that was surely there. Of course, the genomic sequencing was not done in as many numbers as we would want. One more reason for complacency or carelessness in amongst us was the vaccine introduction from 16th of January. So vaccine was only for healthcare workers in the first phase and also frontline workers. The target was 3 crores to be achieved, but then half the target could be achieved, and then the vaccination was allowed to 60 plus population and 45 plus with comorbidities from 1st of March. And then from 1st of April, it was allowed for everyone above 45. That the reason was that looking back the data over last 1 year, the 88% the mortality was amongst people who were either comorbid above 45 years of age or above 60 years of age. That was the reason. So that is why this priority categorization was done for vaccination. But then vaccination was not in as many numbers, and people still were not coming forward for vaccination even in these age groups. Like doctors, our doctors did not get vaccinated when they were encouraged to go for vaccination. A lot of healthcare workers did not take the vaccine. A lot of people had apprehension about co-vaccine because phase 3 trial data was not there. So that was something which went wrong with all of us. And despite that there were 10,000 infections coming each day, we all thought that now the COVID is on its wane. It is going to go from March, and that was naturally a big, should I say that, misconcept, and somewhere we went wrong on this, and that the price we have paid, a very heavy price of it. Then we saw how the infections increased throughout the country, in every state practically, starting from Maharashtra was leading, and then every state followed the suit. And then now, of course, the situation has somewhat under control. But this time, how it was different than the last time was that during the first wave of infections, the children were affected around 4%. In this second wave, the children was almost 7%, 6 to 7%. Although overall, if we look at below 30 years of age, in the wave 1 we had 31%, and wave 2 it was 32%. But the difference, significant difference, was in those infected individuals, the requirement for oxygen was exponentially higher in this wave because of the COVID pneumonia. And also people requiring ICU bed also, and the ventilator was significantly higher. That was significantly different than the first wave. And the reason naturally was, in first wave we saw maximum 100,000 infections in a day. In second wave we saw, as all of you know, more than 400,000 infections per day. And naturally, if the huge, even if 1% patients need hospitalization, those many beds practically could not be created, even with the increased capacity or enhancement of our resources. So that led to a lot of problem of oxygen deficit, oxygen shortage. And then another thing which was actually, I say it's what iatrogenic or our own created, was the remdesivir crisis, which was unnecessary. And this was partly our doctors were also responsible for it, because they did not consider the solidarity trial data, where it was clearly shown that remdesivir neither reduced mortality in admitted patients, nor it reduced the chances of somebody going on ventilator, nor it reduced the hospital stay. So these were three clear interim conclusions from the WHO Solidarity Trial, which was released in November 2020. Similarly, when meta-analysis and trials for plasma therapy were also known, and it was also hyped, and that was something which also was unnecessary. The relatives of the patients were made to run around to procure plasma, to procure remdesivir, and we saw that what happened, that is a spurious drug and also at high cost without benefit. So that also a little bit mismanagement by the doctors also, but naturally this time the severe pneumonia was in higher numbers, and that was reflective in our ICUs, and also despite all efforts, the mortality in ICUs were very high during this time. It was higher in the previous wave also, but because the number was small, it did not, it was not realized. But then during this wave, it was so. And then naturally, we were asking for lockdowns, but that was also both state governments and central government were not very keen, and they were reluctant because of the criticism which was there last year for the lockdown. So the central government left it to the state governments, and the state governments were reluctant to put lockdowns, but finally there was a lot of suggestion that the immediate steps to curb the infections and to bring down the infections, lockdown would be a good idea, and that was considered. And when the limited lockdowns or even unlimited lockdowns, when they were enforced from the last week of April, we could see the results now that the cases have come down, although they are still around less than just 200,000 infections. So we are still not out of it, but I'm sure next 2 weeks are going to be better in terms of even reduced mortality, because the mortality which is being reflected today all over India is amongst those patients who were admitted 10 days ago or 3 weeks ago or 4 weeks ago. So naturally that would continue for a week or so more, and then I think it will ease out. The hospitals have been eased out already, with that the bed occupancy has gone down. Oxygen requirement is not now again gone back to the pre-crisis phase. So I think it was a real challenge for all of us. How could we deal with it? But somewhere we also did not give much attention to that what could have been done. A lot of people got treatment at home also, home isolation, home quarantine, and they recovered. So actually I discouraged a lot of people to go to the hospitals, because what happened, whenever somebody has been diagnosed with an RT-PCR comes positive, people panic. And while there is no need for panic, it has to be, the treatment or the management has to be kept simple. And there have been a lot of experience elsewhere also, like in South Africa, in India also, that in the first week of illness, you just have to bring down your temperature. That's it. It's a viral fever at the end of the day. Yes, it does go down into your respiratory tract. It's a respiratory virus, and it goes down in the lungs and also impacts as lower respiratory tract infection other than the upper respiratory tract infection. But we also know that majority people do recover. All age groups, even elderly have recovered. We have lost young, but we have a lot of elderly people have recovered from the illness. And I have patients on record at home, elderly people who were operated recently for cancer. They were at home. Their pneumonia grade was 13-14 score, and they even did not need oxygen at home, and they recovered. So there have been all kind of a spectrum for asymptomatic or mildest disease to most severe patients. But what we should have realized, and there has been over medication by a lot of people, and in India, not that everyone is treated by a qualified practitioner. There are a lot of non-qualified practitioners also treat and give steroids in large doses, and they are giving steroid from the first week itself, which has created even more problem because it will encourage viral replication as well as it will complicate the illness trajectory also. So if we had kept the treatment simple, that during the first week and that is where the crucial thing is to know the first day of symptom. From the first day of symptom, if we count and see until day 7 or day 8, your oxygenation is okay, your fever is coming down, or you never had high fever, you had always mild fever, the pneumonia issue or the lung involvement or lung inflammation reflects on day 7 or day 8 actually. That is why we say neither use steroids in the first week nor do a CT scan. If at all it is indicated, do on day 8 or day 7 or 8 or 9, because that is the crucial time. And if your oxygen level was 97, 98 during the first week until 7 days, and suddenly on day 8 you see that it is now showing 93, 94, that means you have significant lung involvement with the inflammation, and that is where the indication of a very measured dose of steroid will help. Some people have also used anti-allergic along with that. In South Africa, there is a physician, Dr. Shankar Shetty. He has treated almost 4,000 patients of COVID over last 1 year. What his experience has been amazing, and that is something what he says, none of my patient, hardly one patient required hospitalization, and he followed this basic premise that first week, just take care of the fever, and that is paracetamol, simple. And also what he was doing that day 8, and there is no access to CT scan, there is no access to blood inflammatory markers, you can see that. So these are the things, if they are available, they will help, they will be complementary, but not mandatory. But you have to observe the patient clinically. So if you're on day 8, your saturation level comes down for 97, 98 to 93, 94, that is the time when one should think about giving steroid. And in consultation with your doctor, the dose has to be calculated as per the body weight, and it has to be only a short course of the steroid for 10 days in a tapering manner. And along with that, you can give, and people have used anti-allergic, Montelukast, etc. They have used, and most patients will recover even without oxygen. Some patients may require low flow oxygen. Very few patients would become severe, because what is happening in hospital also, that most of the times these patients are not looked after as well as one would imagine, because there is shortage of doctors to take rounds and see the patient. Most of the time it has been a video round which has gone around in the hospitals. So the patients are put on high flow oxygen, and they don't make any of their own effort. That is where we have gone wrong. And if we had done that, we kept their positive attitude. And because why it is happening? Because there is nobody with the patient actually. Most of the times, nurse will carry out the instructions with the patient. Nobody is there to encourage for that patient to do breathing exercises to increase their respiratory reserve, even if they are not that sick. Because if they are become very sick, then they can't do all this. But in ICU setting, of course, prone breathing also has helped tremendously. In this wave also, in last wave also, it helped. So I think if we could keep the treatment very simple, most patients would recover even with significant pneumonia, moderate pneumonia. The only people who need more attention are those their score is above 17 or above, and people, there have been freelance anesthesiologists and critical care expert I know, even in NCR, they have treated large number of patients with severe pneumonia at home with excellent outcomes. But what they did, if the husband was sick, they made wife in charge of that and to look after, and you will get good food at home. Somebody is there to look after. These things also matter in your recovery. And also the high flow oxygen could also be arranged for some. So somebody called me and said, I have treated almost 300 patients and pneumonia of almost 21, 22 severity also I have treated at home and salvaged. So it is not as pessimistic outcome, or we can still give lot of direction, a lot of encouragement, lot of confidence, lot of counseling to the patient to do on their own. What happens when patients give up and they develop a lot of negative attitude? I think that is what creates a lot of problem. So I think that is where yoga, your meditation, your breathing or your own breathing effort from first week itself. That's why we emphasize when you are not so sick, improve your respiratory reserve in the first week of illness. And if you remain well, which most people will, you will recover without any problem. But some people who become very sick will develop some post-COVID symptoms, as Dr. Sanjeev Sinha very exhaustively told us, and he also answered a lot of questions. So I'll stop here and then we'll take questions at the end now. Let's see if we will hear for this fungal infection problem which has cropped up unanticipated. We never anticipated this, that the mucormycosis will impact so badly during this wave of infections. Thank you.
Thank you, sir. Now, may I now request Professor Soni? We'll take the questions after Professor Soni has discussed about the fungal infections in post-COVID situations. Professor Soni.
Yes, Dr. Bera, can you see my slides?
Yes, please.
Yeah, okay. Good evening all. I'm Dr. Kapil and I will be discussing about COVID-associated mucormycosis, or what popularly or misnomerly or paradoxically called as black fungus. In fact, it's not a black fungus, but somehow in the media it has been named as a black fungus, which is basically a paradox. Right. So, if you think that COVID is a serious problem, and mucormycosis is also 10 times of that problem. And the mortality of COVID is low, but however, if you look at the mortality or the historical figures of mucormycosis, the mortality is somewhere between 70 to 80%. And this is one of the most dreaded fungus infections which is you can think of. So why we have seen a resurgence or increased number of cases or incidence of mucormycosis in this second wave? We have, though there were few cases reported in the first wave as well, but if you compare this wave to the first wave, the number of mucormycosis is exponentially increased. And
डॉक्टर सोनी थोड़ा वॉइस ब्रेक हो रहा है सर, थोड़ा वॉल्यूम रेज करना पड़ेगा.
So we are still trying to figure it out why we are getting so many mucormycosis. If you look at the, I'll start with the case vignette. This is a patient with a history of mild COVID and a recent hospitalization, presented with a history of blurring of vision and a facial edema. We had a past history of renal transfer. Was on we got a CT exam which suggests fungal meningitis, which is loaded in the middle of the wall. Of course, my which was negative. It was started on liposomal lymphocyte B, and the other immunosuppression has been stopped. So this is a common sort of case which we are encountering post-COVID mucormycosis in our clinic or in our practice day in day out. If we look at mucormycosis, not the black fungus, that causes a lot of necrosis on the skin, causes flattening of the or necrosis of the skin or mucous membrane. However, the fungus is quite colorful. In fact, it's basically a broad, non-separate hyphae with irregular branches and broad angle branches. And this is classically seen mucormycosis. If you look at where you will find mucor in your day-to-day life, actually the mucor or the spores are everywhere in our natural environment. They are present in soil, they are present in compost, they are present in animal dung, they are present on the wood and the plant materials, the fruits, the vegetables we eat. And in certain patients, they are in certain populations, they are also as present on the nose and mucus of healthy people. So these are sort of issues fungus have been life for so many years. However, they are not problematic unless you become immunosuppressed. And that's the problem is. So what has happened is, so these are the classical stage which you will see on HNE staining. You will find there's a sporulating, non-separate ribbon sort of a hyphae, and it's a mucus. So what are the risk factors associated with mucormycosis? Now the classical risk factors which have been known to us are basically the diabetes, the use of steroids, malignancies, use of immunosuppressants, and COVID itself. Now, why we say COVID itself? So specifically, what we are intrigued in the second wave is that which we didn't have in the first wave is the change of the strain, and this second strain was more immunosuppressive, and it was more severe presentations in the younger population, and that might be associated. COVID might itself be causing the immunosuppression, and that might have caused the resurgence of mucormycosis in the given patient. Though there have been some hypotheses about the use of the industrial oxygen, the use of spores in the water of the oxygen humidifiers and so on and so forth. However, still these are all other hypotheses. They have not been yet proven. Whereas the improper glycemic controls or the dysglycemia which we commonly see or encounter in the COVID patients, and the use of steroids, which we know, as Dr. Mishra already told, that there was a exorbitant use of steroids. Even and there was the population was taking a lot of steroids even at home. Even with mild disease, the people were taking steroids. And one of the major side effects of steroids is this glycemia, which we often see. Even if you are either diabetic or a non-diabetic, in both the subjects, steroids will cause a lot of fluctuations in the blood sugar. And this glycemia is one of the major risk factors for development of mucormycosis. Now, how do these patients present? They commonly present with the face pain, they have eye drooping, nose stuffiness, headache, dental pain, fever, altered sensorium paralysis. However, there are certain stages which have been proposed for COVID. Now, these are common presentations. You can see that there is a lot of fluffiness below the eye or orbit. You'll find a lot of blackening or necrosis around the nose. So these are common presentations. And for diagnosis, most patients would require either a sampling or a nasal swab or some use of endoscopy, or they may go for a CT or MRI imaging. Now, if you look at the stages, how the mucormycosis involving, initially it causes involvement of the nasal mucosa, and till this involvement of nasal mucosa, the patient will present in form of nasal stuffiness, nasal discharges, foul smell. Certain patients may have epistaxis as well, and this is quite initial stage. If these patients are present to the clinic, now they should undergo a deep nasal swab or an endoscopy guided nasal swab for correct diagnosis. It's important that such patients should not be managed at home. A mucormycosis patient should be hospitalized as soon as possible. A delay in the hospitalization of mucormycosis will cause adverse outcomes and even may result in
failure of medical therapy or a surgical therapy. So initially, most patients will have a nasal mucosa involvement, and that will present as nasal stuffiness or nasal discharge. In stage 2, there will be involvement of the nasal sinuses, and initially it may begin as a one sinus, and then may involve other sinuses as well, including the skeletal sinuses, the bilateral nasal sinuses, and most patients will have some sort of a facial pain or edema. These patients may also have a dental pain as well. Again, these patients need to have undergo a nasal swab or a biopsy for correct diagnosis. In stage 3, once the virus crosses the sinus, it will involve the orbit. And now this is the time a mild disease will convert into a moderate disease. Involvement of orbit would signal that patients would have symptoms associated with pain in the eye or retrobulbar pain, ptosis, or diplopia or loss of vision, or involvement of facial pain or facial numbness. And that would mean the disease has converted from mild to a moderate disease. Again, the earlier the diagnosis, better is the outcome. However, if the diagnosis is delayed, these patients would eventually have high mortality. So it's important that such patients should undergo evaluation as quick as possible. In stage 4, the virus the fungus actually crosses the orbit and enters into the cerebellum and the brain. And patients may present with a cavernous sinus involvement with bilateral process, paralysis, altered sensorium, and dip in the consciousness level or a focus seizures. Both stage 3 and stage 4 are a serious disease. Stage 3 is the moderate, and stage 4 is the florid severe disease of mucormycosis associated with high mortality. So this is how a fungus grows. It initially involves in nasal passages, nasal stuffiness. It involves then goes into the sinuses, which is evident as a headache or a facial pain. Then it involves the orbit, which causes symptoms associated with loss of vision or a proptosis or diplopia or retrobulbar pain. And then the fungus involves the sinus, which along with cerebrum and cerebellum, and that becomes evident as a loss of consciousness or a focus seizures. These are how this is rhinocerebral mucormycosis is one of the most commonest presentations. And what we are witnessing these days is that fungus is presenting, most patients are presenting with rhino-orbital cerebral mucormycosis. Though the fungus may also present as a pulmonary involvement, or it may present as a cutaneous involvement. However, cutaneous and the pulmonary presentations are not that common, they are uncommon, whereas the rhino-orbital cerebral mucormycosis is the commonest presentation. The treatment is quite definite. There are two parts of the treatment. One is the medical management, other one is the surgical management. These patients, as I told, should be admitted immediately. They should not be managed at home. Liposomal amphotericin is a drug of choice. It should be followed by the oral prostaconazole and isovuconazole if available. Surgical management is required for the stage 3 and the stage 4. If there is an extensive involvement of the sinuses or the orbit, orbital accentuation may be indicated. And if the fungus invades the cribriform plate or a cavernous sinus or a brain, and a new surgical intervention is required. So it's a multidisciplinary care is required for the management of mucormycosis. How do you prevent mucormycosis? There is no drug to prevent mucormycosis. And what we are seeing is that most common risk factor is dysglycemia or the irregular blood sugars or the frequent fluctuations in the blood sugars. So that may be secondary to the indiscriminate use of steroids or other immunosuppressants. So avoid using steroids or control the blood sugar is the best way to prevent the progression of mucormycosis. A judicious use of systemic corticosteroids should be there in compliance with the practice guidelines. A judicious use of other immunosuppressants should be there with current practice guidelines. Aggressive monitoring and control of diabetes mellitus is what is needed. There is no nasal drop. I repeat, there is no nasal drop which will prevent mucormycosis. As I discussed, treatment is basically two parts. One is surgical aspect and one is the pharmacological aspect. What I would discuss is
the doses and the evidence which is behind the use of these doses about liposomal amphotericin, posaconazole, or ibuconazole. This has been suggested by consensus guidelines, which is a global consensus guideline from European Confederation of Medical Mycology. What says that is there a role of surgery? Surgery is voluntary. The guideline group strongly supports early complete surgical debridement whenever possible in addition to systemic antifungal. What we do is that at our center, the moment patient is admitted, we start systemic antifungal treatment in form of liposomal amphotericin B. Along with that, we plan appropriate surgical intervention. The role of surgery has been clearly suggested even with the literature that they are associated with improved survival, they are associated with reduced mortality. A team of ENT people, ophthalmology people, neurosurgical people, anesthesiologists, critical care, we are all involved in a multidisciplinary team in care of these patients. Time is more than gold in these patients. More you delay the surgical interventions, the poorer is the outcome. So when to start antifungals, as I said, it should be started as soon as possible. A delay in antifungal increases mortality multi-fold. In hematological malignancies, patients who are, the data is from hematological malignancies, but we can simply extrapolate to COVID patients as well. Which antifungal is better? The drug of choice, as I said, is liposomal amphotericin B. However, the moment the surgical debridement is done, the liposomal amphotericin B is given, we can use posaconazole or antifungals as an addition or a supplementary therapy or a step-down therapy as well. Dose of liposomal amphotericin B, which is suggested, is around 5 to 10 milligram per kilogram. However, the more you increase the dose of liposomal amphotericin B, the higher the chances of renal dysfunction. So what we say is that we strongly against the slow escalation of doses. If there is a moderate to severe involvement of mucormycosis, including the orbital and the cerebral, we go for high doses and then de-escalate. If there is mucormycosis which is limited to nasal cavity and sinuses, we'll start with the lower dose. So strong recommendation with 10 milligram per kilogram for mucormycosis. However, this recommendation has no evidence in a mild to moderate degree. Only in severe disease, we can go up to higher doses and then de-escalate. So what about other amphotericins? In certain places where the liposomal amphotericin is not available because we all know that it's a limited quantity, we are choosing amphotericin deoxycholate or we are using amphotericin lipid formulations as well. However, we must cognizant of the fact that these other liposomal amphotericins are associated with higher acute kidney injury, and they have a questionable venous penetration as well. So these were the trials which had compared the different doses, and they found that the 12-week survival rate was higher with higher doses of ampho-B. However, higher nephrotoxicity was also seen. What are the alternative drugs? As I told, there are two other alternative drugs. One is posaconazole, and the one is ibuconazole, and they have established safety at trial. However, they are used as an additional therapy or a step-down therapy. And these are the literature which supports the use of ibuconazole. They are available from very small case series or a single arm open label trial. Posaconazole is preferred because it's given as an oral supplementation. However, there is no data for primary treatment of mucormycosis, so it's not a primary treatment. As I said, there have been other therapies which have been tried, including the dextromethorphan, the use of iron chelators, dextromethorphan, hyperbaric oxygen therapy, or interferon gamma. These all other adjunctive therapies are mainly investigational or experimental in nature, and they do not form the mainstay of treatment. These are all the experiments which have been equivocal about the efficacy of hyperbaric oxygen therapy or the use of iron chelators. They are still under experiment. There are a lot of uncertainties about the treatment of mucormycosis because we do not know what is the optimal timing of surgery. What we say is that patients should be debrided as soon as possible. We do not have comparative efficacies of Envisome versus Fungisome, which is some modified amphotericin. The other drugs, we do not have optimal duration or the timings of giving the additional therapies. And there is no clinical score to predict mucormycosis in COVID patients. What we have seen with our data, whether the patients were even received steroids or they were received oxygen
whether they have received it or not, we have seen most of the patients. And that's why we say that this emergence of mucormycosis could exclusive phenomena of COVID-19 itself and of coronavirus itself causing changes in the immunity, specifically the strain B.167 strain, and this must be causing a lot of immunosuppression or defects in the immunity. So what is our institutional policy? We go for early diagnosis and surgery, which is a multidisciplinary team. Facilities for surgery has been created, and the protocolized medical management. Take-home message is a limited existing evidence in the management of mucormycosis. We need better understanding of immunopathology, institutional policies to improve the prognosis during the surgery as well as the medical management at the same time, and to start treating these patients as soon as possible. However, we need to identify subpopulations which are very high risk. Antifungal prophylaxis can be useful, but as if now there is no role of antifungal prophylaxis. And besides surgical and pharmacological aspects, focus should also be on the nutritional and the emotional health of the patient. So this is what we are propagating and teaching the general public. There have been organization of clinical surveys, checklist of sentinel signs and symptoms to monitor at home, and what are urgent interventions to minimize. Thank you for participating.
Thank you, Professor Soni, and it was highly exhaustive and technical documents in support of the treatment of mucormycosis in COVID and non-COVID. तो ज़्यादातर लोगों को ये बता दें कि जो मैं अगर छोटे से संक्षिप्त विवरणी दूं तो म्यूकोरमाइकोसिस एक फंगल इन्फेक्शन है जो कि कोविड पेशेंट को या नॉन कोविड पेशेंट को भी हो सकता है। ये पहले भी था, लेकिन अभी क्योंकि हमारा पोस्ट कोविड सिचुएशन में ये नंबर बढ़ गया, इसलिए लोगों को थोड़ा चिंता ज्यादा हो रही है। और इसका कारण हो सकता है कि शुगर कंट्रोल नहीं होना और स्टीरॉयड की यूज करना और अनहाइजीनिक प्रैक्टिसेस जो कि फंगल इन्फेक्शन को बढ़ावा देता है, तो ये कारण हो सकते हैं और ये ट्रीटेबल है अगर आप इनिशियल इसको डायग्नोसिस करें। डायग्नोसिस तरीका है कि साइन सिम्टम्स किसमें सस्पेक्ट करें और ये
I think Dr. Behra disconnected.
डॉक्टर बेहरा बीच में आपकी आवाज नहीं आई।
Sir, I believe Dr. Behra has been disconnected due to power failure. I think he will be resuming after some time.
So I think we can take Dr. Isbud, we can take some questions. What yes, Dr. was summarizing the presentation on mucormycosis. There is also some talk of Candidiasis and also Aspergillus. Other fungi also what have been named as white fungi and the black fungus or yellow fungus. These are all misnomers. All fungus are white. They may get colored with various aspects in the body, like tissue necrosis will make them look black. And if there is some pigmentation over it, it will look yellow, but fungi are fungi and they are opportunistic pathogens, what we call मौका परस्त pathogen है ये। और जो सबसे बड़ा risk factor इसमें आया है वो uncontrolled diabetes, or even with the use of steroid when blood sugar levels have gone high, because we have had some patients who did not have diabetes per se, they have also been affected by mucor. So the success is in diagnosing early your symptoms. If they are starting again after recovery from COVID, any symptom, no harm in getting your checkup done, ENT checkup done, because it is the most common area which is getting affected in this, the whatever we call epidemic of mucormycosis or large number of patients, that it takes entry from nasal passages. As the virus takes it, it gets settled into the nasal mucosa, it grows there, then it goes into the paranasal sinuses, and if somebody has a sinus problem already, this will be more, they'll be more at risk. And then naturally this area we call the dangerous area on the face, because it has a link from the brain direct. The vessels, the blood supply of this area is directly in connection with the brain. So that is what has been seen more, as Dr. Kapil already highlighted, what we call rhino orbito means eye and cerebral mucormycosis. And when it goes into, it becomes invasive, then we call invasive, because when it goes into the blood vessels of the nose, then go into the brain or the eye, that is what we call invasive mucormycosis, which is far more dangerous or has a poor outcome than those who are not having invasive mucormycosis. And Candidiasis and Aspergillus we see more in like oral cavity, in the GI tract, and also this Aspergillus in the lungs. So any system of the body can be impacted, but mucormycosis in this current pandemic is largely impacting the head and neck area, that is nose, the eye and the brain. And if it is limited to the nose, it can be very well treated with the endoscopic surgery, as Dr. Kapil has mentioned, because so that is where the ENT specialist has to look at and do the endoscopic sinus surgery. And some of the patients have required the exentration of the eye to further progress the disease and to salvage these patients. But when it becomes invasive, the mortality is very high. It can range up to 96% or almost 100% in some groups, as has been reported. If it is not invasive, then naturally patients would, provided they get antifungal treatment on time. I think they respond to antifungal treatment quite well, but it has to be started on time. If it is right now, the problem is that amphotericin B liposomal is not available and the treatment is delayed. And the other medicine, what about the Kapil, the posaconazole, is it available?
So, posaconazole is currently available to us. In fact, even the amphotericin was in short supply a few days back, but it has been restored. We are using posaconazole as an additive therapy. It's not the first drug of choice or a step-down therapy. However, given the numbers are so many now, we are starting both the drugs, and in case one or two doses are even missed, we continue with the posaconazole.
Yeah, that's what I thought. Has Dr. Behra joined back or not
no,
yet?
sir. Dr. Behra has not joined back.
Okay, so you can continue.
Yeah, Mr. Biswajit Das or Mr. Kumar, if you have access to the chat box, you can start asking questions till Dr. Behra joins.
Yeah, you can take the questions.
Because I don't have access to the chat box.
Yeah.
Behra is fine. Okay.
Yeah, he has joined back.
No, he has not joined.
Oh,
have joined, sir.
Yeah, he has joined.
अच्छा, ओके, ठीक है डॉक्टर मेरा क्वेश्चन वगैरह जो आया है चैट बॉक्स में मैं शेयर कर लीजिए.
हाँ sir, there are many questions related to the fungal infections. I will specifically first try to ask the question.
Again, problem.
Sir, how long one should be cautious of this fungal infection after COVID? The patient had oxygen support for 7 days. The patient was on steroids and his HRCT was 13. He is now cured of the COVID So how long he should be careful for this black fungus infection?
Kapil?
So, sir, what we have finding patients coming after, most patients would develop fungal infection between 2 to 3 weeks. However, we do have patients coming between 4 to 6 weeks as well. So I would suggest that they need to be careful for next 4 to 6 weeks, and they need to monitor the sugars, specifically the diabetic patients who are on immunosuppression. They need to monitor the sugars very well.
Yeah, I'll add. Basically, if this has to happen, it will happen sooner than later as the time goes by and you are okay. So the basically message is don't ignore any symptom other than what it was when you recovered. So any new symptom you notice around in your nose, whether blocked nose or some discharge, or you are feeling a little feverish again, or so I think don't ignore those symptoms. Get your checkup done by a ENT specialist. I think they can diagnose it quite well on endoscopy because it's a magnified thing they see, and it is possible to diagnose. So I think don't ignore any symptom when you have recovered. A week has elapsed or few days have elapsed and you are again getting any symptom, whether it's heaviness in the head, swelling around the eye, swelling around the half face, or there is hyperesthesia, or there is a dental issue, or getting pain in the your jaw. These are also the symptoms because it also affects the jaw. So don't ignore any symptom. Get your checkup done. The longer you have gone after the recovery, lesser will become the chances of acquiring the fungal infection.
So the most vulnerable period is first 2 weeks after discharge.
That's right. Yes, Dr. Behra.
I think we have lost him again.
Okay, so can you?
रेशमोद और किसी के पास नहीं है क्या चैट बॉक्स का एक्सेस?
Sir, ये विश्वजीत दास?
Sir, with your permission, I'll read out few questions.
Yeah. Go ahead.
Sir, has mycosis anything to do with face mask usage?
No, it has not, but people have linked it with that. If some people are using linen mask and they are not changing it or washing it every day, and they are not keeping the hygiene of that mask. So people have indicated, but I don't think it has been a major reason for fungal. Rather, it should prevent actually from fungal infection happening. But it has been suggested by some. So just take care of the hygiene of your mask. If you are using a linen mask, wash it daily. Have 2-3 masks so you can change it every day and dry it in sun, basically.
The next query is, within what time span can black fungus appear in a post-COVID patient?
This, I think we have already covered this. Within 2 weeks of recovery is the highest maximum chances of acquiring this infection, because at that moment of time you are most immunosuppressed, you are just recovering, your diet may not come back to normal, and you may still feel weak. So I think that is there, but and also nasal hygiene, to maintain nasal hygiene is also extremely important, particularly diabetic people, and that is where I say this jal neti, etc., which is advised, which is recommended by Ayurvedic practitioners, comes very handy to maintain nasopharyngeal hygiene. It's very, very important, because what fungus does, it enters through when we breathe and it lodges itself into the nasal mucosa, and when it becomes invasive, it creates problem.
I think there is no more queries for black fungus, but generic questions. Can we take those questions?
Yeah, please go ahead.
why doctors of big hospitals of Delhi and Mumbai, Raipur were prescribing steroids and blood thinning agents from day one? Were they misguided by some study in the reputed journals? Even our most liked uh, Dr. K.K. Agrawal was advising steroids and ivermectin in national and channel for cure of COVID.
No, I think there is a standard protocol, as I just mentioned. Minimum medications need to be used in the first week, only to bring down your temperature. I think that should be the focus. There are protocols. You take ivermectin, it is given only for 3 days. There is a fixed dose which is given for 3 days. People also have used doxycycline along with that in that usual protocol which is recommended by some UP governments also. You can do that. But steroid is surely not recommended as a drug in the first week, and rather it will harm by encouraging viral replication more, because it is an immunosuppressive agent. It's anti-inflammatory and immunosuppressive. So if that has been prescribed, it is wrong. It should not have been prescribed. Only when your oxygen level goes down on day 8 or day 9, then there is an indication for steroid, and that also depending upon your body weight, not just blanketly 32 milligram twice a day for 10 days. Mild pneumonia also doesn't require any steroid whatsoever. If your score is less than 8 or less, you don't need. Young people don't need. Non-diabetics will not need. So I think it is, for us also it becomes, I got a steroid stopped in many patients who approached me. Some hospital recommended, some without even knowing whether pneumonia is there or not, 32 milligram twice a day steroid. I said, if you're tall, you just get a CT scan now and let me know the report. And it was mild. I said, you don't need steroid. And they never took the steroid. And they were all right. It is difficult for doctors because it's so much prescribed in the community. It's very difficult for us. I actually advised against CT scans in young people, but the GP was prescribing. So naturally, the people are so fearful, they are so panicked, so they err towards getting it done rather than not getting it done. So that is the problem. The people are also, so it is our duty to actually counsel them that you need not to worry about if your fever is okay, your saturation is okay, you are okay. It's a viral illness. 95%, 97% people are just getting all right without any problem. It's only 2 to 3% people getting sick. And that we can easily separate out.
Thank you, sir. Next query is, if contracted COVID after 6 weeks of Covishield of first dose, when should one take the second dose?
Again, this was answered by Dr. Sanjeev Sinha already when he left. There is no hurry then for you to take a second dose. It's already government guideline are clear. When you get the COVID itself, you get immunity and that will act as a booster for you. If you had taken a dose 6 weeks prior, then you get COVID, that would also give you some protection. But yes, you take the second dose after you recover well and then see how much. Now the spacing is about 12 to 16 weeks between 2 doses of Covishield. So just gauge that, and after recovery, 3 months time. After 3 months, you can take the second dose.
This query is from Dr. Sasmita Das, GM Medical. Sir, why we have stopped plasma therapy now, though we practice this as supportive therapy in the severe COVID affected patients in past?
Kapil, would you like to respond to this?
Yeah. So a year back, when the disease was new and we didn't have that much of information about the interventions which would be effective against the disease, plasma therapy was one of the mainstay of the therapy, and we were giving plasma in hoping that the high titer antibodies would prevent the virus replication.
However, since 1 year now, we have a lot of information available about the efficacy of plasma therapy. And in multi-centric trials and even in most patients, the plasma therapy has shown that it would prevent progression of the disease or it would decrease the mortality. However, saying that what we realized at our own institute, giving plasma in the late stage of the disease, when the disease is mainly because of immunity or a hyperimmune response, the plasma is not going to be effective. At all, it is going to be effective. It should be effective at very early stages of the disease, and when the disease is mild. However, most patients would recover by their own, and they would not require any intervention. So that's why the plasma therapy has been discontinued and not been included in the protocols, or even in national or a WHO protocol. The evidence haven't shown any benefit of the plasma therapy.
Thank you, sir. Sorry for the discontinuation in my this webinar. I was out of this session. So there has been many questions answered, many queries are still pending. They're all general in nature. So I would request these the participants, they can put in their queries to our doctors who are on the NTPC or on the panels, and they can also get back the answers. And I now request our CMO CC, Dr. Azir Rizwood, to please propose the vote of thanks.
Thank you, Dr. Vera. As we were whitewashed by the second wave of COVID, and we struggled a lot, and we are slowly coming out of it. I hope everything goes as per the graph and it declines. And during this tough time, I'm extremely thankful that our panel of experts, Dr. MC Mishra, Dr. Kapil Dev Soni, and Dr. Sinha, they accepted our invitation and came in this webinar to help our people to understand what's going on in India and across the world, what new has happened, how the course, how the virus is taking its course and all that. So again, I thank Dr. Mishra and Dr. Soni for your presence. I'm extremely grateful to you. I also thank our Director of Finance, our Director HR, Sri D.K. Patel sir, Director of Projects, Sri Bhattacharya sir, who were present with us. And I thank all the audience who were extremely patient. And we had approximately 500 people attending this webinar. So I hope they have taken the lesson necessary to keep the precautions on, even though the pandemic, the wave of the pandemic goes down. We should not let our guards down, and we should continue to take precautions just to prevent another wave, because as is common with the pandemics, they go on recurring in waves. So it's not uncommon to find a third wave or a fourth wave. So, but if we take due precautions, we'll surely be fighting it out. So thank you again. Thank you all for joining us. Thank you.
Everyone.
Thank you, Dr. Mishra. Namaskar.
Take everyone vaccine. Vaccine must be taken by everyone. As and when you get it, take any vaccine which comes your way. That will take us out of this pandemic towards the end of the year. So keep safe, keep healthy, keep using masks, 2 masks, and that's it. Thank you, Patel sir.
Namaskar. Namaskar, sir.
Thank you, sir.
Thank you, sir.